In the final part of bones and bone structure, we'll take a look at bone remodeling, then we'll take a look at how exercise, nutrition, and various hormones have an impact on bone, and then we'll finish the chapter by taking a look at fractures and how bone repairs itself in fracture repair. So let's take a look at bone remodeling first. It's important for you to realize that bone remodeling is a continuous process. This is something that occurs throughout our life. Bones aren't like a piece of wood that don't change, right? They're constantly changing based on our activities, what we do, what we don't do, how much nutrition we get. So it's a constant process. It involves all the cells that we mentioned in previous parts of this chapter. It involves the osteocytes, osteoblasts, and the osteoclasts. Normally, the activity of all these cells are in balance so that we have nice, strong, healthy bones. However, if bone removal is faster than replacement, then our bones will weaken. Just the opposite. If deposition predominates, right, if we're depositing more bone than we're taking away, then our bones will strengthen. And that's the ultimate goal. We want to have nice, strong, healthy bones. One of the ways that we can have nice, strong, healthy bones is to do exercise. Our bones adapt to stress that we put on them. So, mineral recycling allows for bones to adapt to different stresses. The best way to strengthen our bones is to put heavy stress on the bone, right? Heavily stressed bones become thicker and stronger. So it's important for you, your family, your patients in the future, do weight bearing exercise because that stimulates the osteoblasts. If you remember, osteoblasts, when they're stimulated, they lay down new bone matrix, right? So they're going to make our bones stronger. If we don't exercise, or we kind of become like a couch potato, we find that our bones actually degenerate rather quickly. Look at this statistic. Up to 1/3 of bone mass can be lost in a few weeks of inactivity. This was seen early on when they were putting astronauts up into space. One of the things that's missing in space is the force of gravity. So they found that when the astronauts returned back from space, their bones had already degenerated rather quickly or demineralized rather quickly. All right, so weight-bearing exercise is very important. Here's some nutritional things that we can do to make our bones strong. Right, we want to have adequate amounts of calcium and phosphorus in the diet. We also want to have minerals, magnesium, fluoride, iron, manganese. Right, these are all minerals that are stored in the bone matrix. Now, we can get a good amount of calcium and phosphate into our bones from our digestive system. The way we can do that either by taking vitamin D3 or it's in part of our food or if we go out into sunlight. Vitamin D3 is converted into calcitriol. I cover this in the skin or the integumentary chapter. We go through the whole pathway. So if you want to take a look at that, you can review that. But vitamin D3 is converted to a hormone called calcitriol. That calcitriol is actually going to be made in the kidneys. It's released in the kidneys or from the kidneys, and it goes to our digestive system and it tells the digestive tract to absorb more calcium and phosphate. Okay, so vitamin D3 becomes calcitriol. Calcitriol goes into the bloodstream. It tells the intestines absorb more calcium and phosphate so that our bones are going to be strong. And like I said before, we said last dot right here, vitamin D3 is what's going to make the calcitriol. We talk about cholecalciferol in the integumentary chapter. Okay, so it's really important. Calcium, phosphate, minerals, again, adequate amounts of vitamin D. This way we get our calcitriol being made. Some other important nutritional substances that we should be ingesting. Vitamin C. Look at this, required for collagen synthesis. Right? If you watched previous lessons on this chapter, we saw that 1/3 of our bone matrix is made up of collagen. It also stimulates osteoblast differentiation, right? The formation of osteoblasts. And again, anytime osteoblasts are around, that's good. They produce bone. Vitamin A also stimulates osteoblast activity, and then vitamin K, vitamin B12 help to make some of the other bone proteins. Now, there are a number of hormones that are important in bone health and bone growth. We'll mention them in this chapter when we get to anatomy and physiology too, and you study the endocrine system. We look at these hormones in much more detail. Two important hormones that actually stimulate bone growth are known as the growth hormone. Sometimes we say human growth hormone, right? We say HGH. And thyroxine, you may know this as thyroid hormones. If you just want to jot down over here, T3 and T4. So, growth hormones and the thyroid hormones stimulate bone growth. Some of our sex hormones in females, estrogen, in males, testosterone, they stimulate our good old friends, the osteoblasts. So these hormones are hormones you're going to talk more about when you do the endocrine system. The hormones that I want to speak about in this lesson are going to be the parathyroid hormone and calcitonin. Their job is to maintain calcium balance, right? If you remember, this word from our first lesson, chapter 1, is called homeostasis. We need to make sure that calcium stays at a certain level so that we have normal bones, but calcium is also important for muscle contraction, membrane transport. It is such an important ion that we need to regulate it. All right, so the two hormones we're going to look at in detail for this chapter are going to be parathyroid and calcitonin. When you review them or see them again in endocrine system, right, it should be a nice review. So let's take a look at why calcium is so important. Right, bones store 99% of the body's calcium, and like we said, or just on the previous slide, some other minerals also. Calcium is the most abundant mineral in the body. Calcium ions are vital to many physiological processes. So this is just kind of an FYI slide, but it's actually showing you the components of bones, all the different minerals that are stored in bones, some of the organic compounds, mostly collagen over here. This is kind of an FYI type of slide. I wouldn't ask you anything directly from the slide. It's just kind of interesting. So let's take a look at the again the homeostasis of calcium. Right? Calcium ion concentrations in body fluids must be closely regulated. The two hormones, like I said, that we're going to take a look at are the parathyroid hormone and calcitonin. And we're going to see in a second that both of these hormones, they target our bones, the digestive system, and the kidneys, right? So both hormones are going to have an impact on the bones, digestive system, and the kidneys. So let's take a look at parathyroid hormone. I'm going to skip this slide and I want to take you to a diagram that this is from the Martini textbook. They do a really good job with this. Let's just say our blood calcium levels diminish for whatever reason. Somebody's not out in the sunlight, they haven't been eating properly, or it's just we've used up the calcium in the blood and the blood levels of calcium have gone down. Normally, our blood calcium levels are about 10 milligrams per deciliter. So in this example here, what they're showing us is that the blood calcium levels have gone down to 8.5. So what happens is once the blood calcium levels go down to 8.5, there are some glands, they're right behind our thyroid gland. They're called the parathyroid glands. Para means around. Right? So these are four little glands that are around the thyroid. And what they do is they monitor calcium levels, but they only become active when calcium levels go low. All right, so again, if normal blood calcium levels are about 10, once they go down to 8.5, the parathyroid gland is activated and it releases a hormone called parathyroid hormone. Right? We usually abbreviate it PTH. This hormone now goes into the bloodstream and it targets the three organs I mentioned on the previous slide: bone, the intestines, and the kidney. So here's what happens. Let's look at the kidney first. Once the parathyroid hormone goes to the kidney, the kidney is told not to release calcium into the urine, rather save the calcium in the blood. Right? You may or may not know this, but our kidneys filter the blood. So by not putting the calcium into the urine, we keep the calcium in the blood. And check this out. It stimulates more calcitriol to be released from the kidneys. And if you remember from the previous slide before, calcitriol helps to increase our blood calcium levels. PTH also targets our intestines. So in the Martini book, this is the representation of our intestines. And PTH tells the intestines to absorb more calcium. That's the same thing calcitriol is doing. So between not urinating out calcium, blood calcium levels should go up. Absorbing more calcium, blood calcium levels should go up. The third organ that's being targeted is the bone. So PTH, the parathyroid hormone, turns on the osteoclasts. If you remember, osteoclasts break down bone. So what they're going to do is they're going to release the calcium into the blood. So all of these effects, the kidney conserving calcium, right, not putting it out into the urine, the intestines absorbing more calcium, and the bone releasing calcium from its stored form, are all going to increase the blood calcium level so that it goes back up to about 10 milligrams per deciliter. Okay, so this is a great picture. They do a good job with this in a visual way to show you how the hormone works. I'll go back to the note for a second. So again, the parathyroid hormone is produced in the parathyroid gland, right? These are glands that are right next to our thyroid, and their job is to increase blood calcium levels, all right? So whenever blood calcium levels go low, they're going to stimulate the osteoclasts to break down bone. They're going to tell the intestines to absorb more calcium, and they're going to tell the kidney not to release the calcium into the urine. Right? It stays in the blood. Just the opposite. The second hormone is an antagonistic hormone, meaning it has an opposite effect of parathyroid hormone. Again, I'm going to skip this slide first. We'll go back to it. Let's go to the diagram first. So here's another situation. We said that normal blood calcium levels are about 10 milligrams per deciliter. But in this individual, or this example, blood calcium levels are elevated. All right, so for whatever reason, somebody has high blood calcium levels. So the parathyroid glands, which we just talked about, don't care about that. The gland that is going to monitor high blood calcium levels is the thyroid gland. Now, the thyroid gland has a certain type of cell in the gland called the C cell. Right? When you're in anatomy 2 or you're learning the endocrine system, you may also hear it as a parafollicular cell. It's another name. The C cells are activated when our blood calcium levels go up. They release a hormone called calcitonin. And like I said a second ago, this is an antagonist hormone to parathyroid, meaning it's going to have the opposite effect of the parathyroid hormone. So you could probably guess what's going to happen. Once the hormone goes into the bloodstream, it's going to tell the kidney to excrete calcium ions. Right? So it's going to get rid of some of the extra calcium ions. Now, calcium is going to be excreted into the urine, right? So you'll have more calcium in the urine. We'll release less calcitriol from the urine, which means that less calcium is going to be absorbed. And that happens to be the second target organ, calcitonin, also targets excuse me, the intestines, and now it tells the intestines to not absorb as much calcium. Calcitonin also goes to the bones and it turns the osteoclasts off. We don't want to release calcium into the blood from the bone. So it's going to shut off the osteoclast activity. So the hormone targets, again, kidneys, intestines, and bone. Again, at the bone, by not activating the osteoclast, by actually inhibiting the osteoclast, less calcium is being released from the bone. Targeting the intestines, less calcium is going to be absorbed. And targeting the kidney, it's going to increase the amount of calcium released from the kidney. More calcium is going to go into the urine. So all three effects, one, two, three, what they're going to do is they're going to lower blood calcium levels. So these two hormones, calcitonin and parathyroid, are constantly battling each other because they're antagonistic to keep blood calcium levels about 10 milligrams per deciliter. So just to go and make sure we cover the note real quick, calcitonin, like we said before, is secreted by the C cells in the parathyroid gland. I'm sorry, C cells in the thyroid gland, and they respond to high blood calcium levels. And again, they're going to inhibit the osteoclasts. They're going to cause more calcium to be released from the kidney, and they're going to decrease the amount of absorption of calcium from the bloodstream. Again, good picture. The picture does a good job with this. So the last topic of our bones and bone tissue is going to be fractures. All right, most of us know this already. A fracture is really just a crack or a break in the bone, right? Someone says they broke their bone, right? They usually have a fracture. It's usually due to physical stress. However, as you go on in your studies, you'll see that there are pathologies, which are diseases that can cause breaks of bone. It can be metabolic diseases, cancer, that type of thing. When a fracture is open, meaning that the bones have penetrated through the skin, you're going to call that a compound fracture. When the fracture is closed, we also call that a simple fracture, right? So the bone is broken, but we can't see the bones penetrating through the skin. So there's a bunch of different types of fractures. Let's take a look at these guys over here. We'll take a look at transverse, displaced, a compression fracture, spiral, epiphyseal, or you could probably guess just from the name that means the growth plate. Comminuted, we'll take a look at green stick, and then two different types of specific fractures, one in the wrist called the collise, and one down in the ankle called the Pott's fracture. So let's take a look at a transverse fracture. So you know the word transverse means across. So when a bone is broken and it breaks across the bone, like this, see how this one goes directly across, that is a transverse fracture. So this happens to be the forearm. This is the ulna bone. This is the radius bone right over here. So it happened to be a transverse fracture of the ulna. A displaced fracture means we have a fracture where the bones have lost their alignment. If I go back to the transverse fracture, these bones are pretty much in line. They're a little bit off, but not too bad. But look at this one. This happens to be, it looks like the humerus, where the bones are really out of alignment. They have to go in probably surgically and repair this and realign them back up. So this would be a displaced fracture. A compression fracture is a fracture we see in the spine. So just to show you, let's look at this vertebrae here. This is box right here. This is a healthy vertebrae that has a nice height to it like this. When the fracture occurs in the vertebrae, it like pancakes down. It actually gets compressed or pancakes. So now look at this vertebrae here. Here's the body, and you can see it's not nearly as high as it was over here. Here's the top of this vertebrae. Here's the bottom of this vertebrae. So compression fractures is a type of fracture we see in the spine in the vertebrae. A spiral fracture is a fracture that usually occurs when somebody twists a bone. This one happens to be in the femur, where it actually kind of starts up here and it spirals around in like a S shape down this way. We see them a lot down in this bone here, the tibia also, when somebody plants their foot and they twist and the bone will break in a spiral. Epiphyseal fracture, we said, epiphyses means the growth plate. So if a fracture occurs and it disrupts the blood vessels at the growth plate, that could actually inhibit the bone from growing any further. So that's an important thing, as far as children, that they don't want to fracture near the epiphyseal cartilage. A comminuted fracture is where we have a fracture with multiple fragments. So if you take a look here, this is the femur, the thigh bone. Here's the top of it. Here's the bottom of it. And look at this mess in the middle over here. There's multiple fractures right here. Multiple fragments, I should say, not fractures. Multiple fragments. So comminuted, right, means somebody really had pretty bad trauma for a bone to break into multiple fragments. A green stick fracture is a fracture that we see in children many times because their bones haven't fully calcified, where the bone will splinter. So here we can see the fracture partially goes through and then it actually goes down along the bone this way. Right, so a lot of times we see that in children. This is a Callus fracture. This is a specific type of fracture that occurs in the wrist. This is the radius bone right here. This is the ulna bone, and the radius actually breaks distally, and then this fragment here actually a lot of times will go posterior backwards, and you can see a big bump on the wrist. Right, this is called the Callus fracture. A lot of times people get this when they fall and they put their hand out to brace themselves. It'll break right at that radius. Callus fracture. And then the last one is a Potts fracture. This is the fibula. This is the tibia. Right, there's a part of the bone called the medial malleolus here and the lateral malleolus. They both have broken, and a lot of times the ankle bone, the talus here, will also dislocate. So it's kind of like a fracture, usually right across here. It can be quite complex. A lot of times the tendons and the ligaments here are all torn apart. A lot of times somebody that jumps, as they say, from a roof or something like that, or out of a tree, they could get a Potts fracture. And so Potts fracture is a fracture of the ankle. So let's finish this chapter by taking a look at fracture repair. We typically will divide fracture repair into four parts. We'll take a look at the first part. It's called the hematoma formation, which is really nothing but a blood clot. Then we'll start to get healing by forming a callus. That callus will be replaced by spongy bone, and then we'll replace that spongy bone by compact bone and get remodeling. So let's take a look at fracture hematoma formation first. I'm actually going to go skip the slide for a minute. We'll go back to it. Let's take a look at the picture first, and then we'll go back to the notes. So this happens to be the tibia bone. Say someone has a transverse fracture right here. Once the fracture occurs, bleeding happens right in between the fragments. So if you take a look here, eventually this all fills up with blood, and the blood brings white blood cells in here which break down these fragments. They clean up the area. It produces a mesh, a network of fibers to start to do the healing process. Right? So think of hematoma. If you want to highlight right here is a large blood clot. This occurs right after the fracture occurs. It happens right away. And like I said, we produce kind of a fibrous network, a bunch of fibers inside the fracture. And also it cleans up any dead cells in the area. Actually, even some of this bone here will actually be broken down. You can see they kind of highlighted it in brown. This bone here, this will all be cleaned up until we have a nice clean fracture end right over here. This will actually be nice and straight. The second stage is known as callus formation. Right? So here, cells of the endosteum, remember that was that inner lining, and the periosteum, they're going to divide and migrate to the fracture zone. So they're actually now producing the cells that are going to assist with healing. We'll go back to the slide, but let's take a look at the bone. So if you take a look now within the fracture site, you can see that it's much cleaner up over here. We start to get some spongy bone forming inside the fracture, as well as some cartilage on the outside. So all of this is cartilage, right? So we're starting to get now some union of this fragment of bone up here with this fragment of bone here. Spongy bone is uniting the two parts here, and then cartilage is uniting the two parts over here, right? So that's our callus. The spongy bone on the inside is known as the internal callus, and then the cartilage on the outside is the external callus. All right, so just to go to the picture, the spongy bone is the internal callus. All right, we have it labeled up over here, and the cartilage out over here is the external callus. And we can see the periosteum out over here. This is where a lot of those cells are coming from to repair the bone. Now, over time, the whole fracture site is going to be replaced with spongy bone. So if you can see, we had that internal callus here with spongy bone, but now look at the external callus, which was all cartilage in the previous slide, is now all spongy bone. So at this point, we have bony union. The fracture has been kind of healed at this point with a spongy bone, right? Is the bone strong and normal? No, not at this point. It's going to need to go through some remodeling. And that's our last step, where we're now going to form compact bone. If you remember, compact bone is the strong bone. So over time, the osteoblasts and the osteoclasts, they will remodel that fracture. That could take weeks, months, or even a year to get full remodeling. And many times the bone that was fractured is actually thicker and stronger than what it was prior to the fracture. And a lot of times, even if you look at an x-ray, you don't see that where the fracture was. It's hard to tell sometimes. So you can see at this point we have nice, bony union. Eventually, this will all remodel, where we get a nice medullary canal in here. We'll get the bone all to be flush over time. So the compact bone will form and remodel and just look totally, totally normal. Those four pictures were from the Martini book. This is from the Tortora book. Again, same type of thing. You could see the hematoma being formed here, and we're getting the cartilage, the callus formation in the second stage, then the spongy bone in the third stage, and then eventually compact bone in the fourth stage. Nice compact bone here, right? Everything's nice and healed. So it's just a different interpretation.